Good morning. Let's get started. As I always say, Dr. Espay doesn't need much introduction. He's internationally known, but also well loved in Cincinnati. The only thing I'm jealous of is that he has more participants this month in the Zoom meeting than I did last month. I guess he's a little more popular than I am.
I doubt it. I
Okay,
doubt it.
Alberto, you're on.
All right. Well, thank you. I don't know if when people say you need no introduction, I'm not sure if that means there is no budget for an introduction or what, or whether there really isn't
Well, the last time I printed your CV and, I'm not going through that again.
not going through that. Well, thanks for sparing everyone from that. Um, well, I'm very happy. Thank you for organizing and inviting me, Maureen, and of course the Parkinson Support Wellness. It's a organization that we're very proud of. I'm delighted that you're all connected to it. Um, I will start by saying that what I will cover over the next, say, half hour, 40 minutes at most, so that we have time to discuss, is going to be related to what's most important in today's research, and that is to affect the disease, not to help the symptoms. There is plenty of progress on symptomatic development, so therapies that help people do better, feel better. And I'll speak about the progress on the latest advances of that at the Sunflower Symposium in August. Rather than doing today what I would then also do in August, I decided that the best strategy for today's session is to go as much in detail as to where we are with regards to disease modification. Disease modification is the term used for the program in research development that is meant to affect the disease, not just improve the symptoms. Symptomatic development is one thing, and disease modification is another one. But I'll tell you that there is a lot of confusion in the field about this, and so I will hopefully make the case that this is something that we need to have very much clear understanding of, because it is what's going to make the biggest difference in everyone's life, and that is something that we're very keen on in Cincinnati. So disease modification is really what we're going to be talking a little bit about here. So these are my disclosures. There is always disclosures. As you see, I am a consultant or provide a scientific advisory to a variety of different companies. I'm also a chair of the Data Safety Monitoring Board. Well, I've been involved in trying to move into the next level of development by co-founding a company, although I have zero interests financially, because I want to remain as unbiased as possible. I don't want this to be made on the basis of personal incentives. So the first thing to try to get into is this idea of how we came to the idea. How do we call Parkinson's? Well, it turns out that it's a concept that came in the late 1910s, and we had to wait till we had uh, autopsy material of people who during life had that thing that Dr. James Parkinson's in 1817 described as the shaking palsy. Tremor, slowness, stiffness. There must be something about these people, Dr. James Parkinson said, that must mean they have a disease. And it wasn't until the early 1900s when it became clear that by looking at the brain autopsies, that there were these things called Lewy bodies that were common among those who had what James Parkinson identified as the shaking palsy, which then Charcot in France in the mid 1850s decided it was worth recognizing James Parkinson's observations with the name of the disease. But at the core, this is a forensic approach, meaning that we're looking at a crime scene. If by that we mean the tissue of someone who's died, so that brain autopsy becomes a crime scene. And what we're trying to look is, how did the crime get going? What are the conditions in which the crime took place? And I argue that a lot of the problems with this original definition of Parkinson's, which still is with us today, is called the clinical pathologic definition, is that we conflated the corpses in the crime scene, the Lewy bodies, as the perpetrators of the crime. And imagine if you see a crime show and you see any of the investigators coming onto the crime scene and saying, look, who committed the crime here, bloody bodies. Those are the ones that certainly got this whole thing going, right? This mess came from them. No, the whole thing about a crime scene shows that you know that what you're seeing there is a scene that allows you to try to make sense of how the victims became the corpses you see there. And so what we've done then is to recognize that we had committed the original sin of research in terms of conflating correlation with causation. Lewy bodies are highly correlated with Parkinson's, but they do not cause it. They are the victims, and I'll show you in what way they are the victims. But because the idea of Parkinson's came to be that condition that's defined by the accumulation of Lewy bodies, then it turns out that every discovery ever made in any one or any family of Parkinson's has been considered to be a puzzle in the, or a piece in the puzzle to Parkinson's. And that's a problem because then essentially this is now a 10, 11-year-old figure of a paper that looked up to that point for all the different molecular biological changes that were thought to be associated with Parkinson's. And in actually the idea of a puzzle was created there, well, or was emphasized there. I think we have been thinking that Parkinson's is a puzzle for a long time, but this is making the figure of a puzzle real. And of course, if you can think of a company coming into the space of medicine saying, we have a product that does something in the, it enhances mitochondrial function. What kind of disease is there that affects mitochondria? Oh, Parkinson's, right? Because here you see the mitochondrial dysfunction is one of them. But essentially, there isn't any particular aspect of the cellular biology that isn't shown to be affected in Parkinson's, and that's a problem. I think is a lumping approach to Parkinson's. Anything that we ever discover about Parkinson's somehow applies to everyone with Parkinson's, and it is, there is no such thing as Parkinson's as disease. It is not a single puzzle. There are many puzzles, as many perhaps as people living with Parkinson's. Now, the latest compilation of the research on Parkinson's is in this particular assessment. This is essentially showing you in one figure everything that's in the pipeline, everything that is in the research of Parkinson's right now. And the first message to tell you is, as you see, there is a richness of molecules, right? I mean, the idea is not for you to read each of the names. The idea is for you to see the richness of it. So plenty of therapies, plenty of investment. So one message is, it is not that we don't have money enough into Parkinson's, that we're not putting enough of an investment here, or that there are not enough molecules. The problem is of a different nature. We're seeing that the disease modification is in the other side of the same coin. This is actually depicted as a bit of a coin. And if you can imagine, it's as if you, in one side have symptomatic therapies and the other have disease modifying. Now, symptomatic therapies are very, very different. And we've done a really good job with symptomatic therapies. But in symptomatic therapies, you're chasing that which is common across a population. And one thing that's an eloquent common denominator in Parkinson's is dopamine deficiency. We know that with the lower production of dopamine comes the symptoms that we recognize as those of Parkinson's, the slowness, the stiffness, etc. And so if we can then replace as much as we can of the dopamine, we'll get people to feel better. That's a symptomatic therapy. And we actually have pretty good successes with that. So this is a bright spot in research on Parkinson's disease. And there are ever so often new therapies coming into the same space, trying to help with something that appears to be deficient, and in so doing, helping the symptoms. But as you see here, there is the disease modification in the same category. And for disease modification, we no longer can accept lumping, meaning we can no longer say, if you have Parkinson's disease, you are a candidate for a therapy that enhances mitochondria, because we know mitochondrial dysfunction is part of Parkinson's disease. No, we can't, because we know that it cannot be that everyone with Parkinson's has mitochondrial dysfunction. Is it possible that there is a subset of individuals in whom mitochondrial dysfunction is important? Sure, but how do we know who they are? These trials aren't selecting for people who have a dominant mitochondrial dysfunction as their mechanism for Parkinson's. And so,
Alberto,
yeah.
excuse me, can you just explain what mitochondria is?
Yeah, absolutely. Sorry. So mitochondria is one of the aspects of one, it's called an organelle. It's a component of the cell, and it's in every cell of our bodies that has to do with energy production. It generates something called ATP. And back in the day, in the 80s, there was a group of people that were injecting themselves with synthetic opioid that turned out to have been contaminated with a mitochondrial toxin called MPTP. This became famous in a book called The Case of the Frozen Addicts. People overnight develop Parkinsonism. Not something that we today would call exactly Parkinson's. There are many different ways in which they were different. But the key thing was that overnight they lost their mitochondrial function, and they developed something that looked like Parkinson's overnight. And so one of the reasons why we think mitochondria is affected in Parkinson's is from back in the 80s, that mitochondrial poison that created a form of Parkinsonism that vaguely is reminiscent of that which today we call Parkinson's disease. So yes, thanks for the question. The idea, though, when I use the example of mitochondria, is not to say something specific about it. It's just to kind of give you an idea that it is one part of many other elements of our biology of aging. And sometimes actually it is affected, but the issue is, it affected upstream? Is it something that happens at the beginning and creates a disease, or is something that's affected downstream? That ultimately many processes do lead to the involvement of certain aspects of the cell function among the mitochondria, and therefore trying to restore that might not really help us much. And by the way, there has been a number of therapies that enhance mitochondrial function tried in Parkinson's, and of course they haven't worked because we have not been able to select appropriately for them. And this is why we have what I call a cemetery of drugs. Again, it's not that we haven't tried. We have tried, but we're one of the few fields of medicine that use clinical trials to test, quote, safety and efficacy of molecules, which is good, it's important, but we need to also use trials to test hypotheses, and we don't tend to do that. So when you see a report of any of these trials, the report doesn't start by saying, we conducted this trial to test the hypothesis that, let's say here, CoQ10, right? That would be the mitochondrial enhancer, for instance, in this case, that coenzyme Q10 enhances mitochondrial function and by doing so will improve patients. We don't state the hypothesis. So when the study is negative, we think the problem is the molecule. We don't think the problem is the idea behind the trial, the inspiration for it, what we call the hypothesis. So we in neurology of Parkinson's have among the lowest rate of hypothesis falsification. We come up with hypotheses which are interesting, and then we never, ever divorce them. And that's a problem in science. Science is the conduct of research to test that ideas are not false, because they are false until proven otherwise. And this is kind of how science separates itself from other fields of endeavor. So we're in the process of testing new molecules, but we're not in the process of testing new ideas, nor in the process of recognizing that part of the problem here is that the many medications tried, the what's, haven't been given to those that might most likely benefit from. So there has been a what-who mismatch. In the who, the people that we want to benefit with a therapy that presumably affects his or her disease must have some kind of proof that tells us that there is a mechanism in their Parkinson's or driving the Parkinson's that is abnormal for normal aging, that is accelerating aging in some extent, and that renders that individual susceptible to benefit from this from this medication. So what we typically do today, and this is not in Cincinnati, well, I guess we're part of this by legacy, I suppose, but the PPMI, most of you will know, is the idea of finding biomarkers of progression of Parkinson's. And the idea with that particular biomarker development program, as well as that of many others, is that if somebody like me at the bedside says, you have Parkinson's disease because you check all the boxes for the criteria that my forebears have put together, trust me, I'm an expert, and that's the final diagnosis. And by the way, we're interested in finding biomarkers progression. So since you have this, it'd be great if we can put you into this study, into a bucket called Parkinson's, to try to compare that to another bucket. And this is the bucket of healthy controls, people in whom we don't appreciate any neurological symptoms. And what we want to do is we want to measure as much as anything can be measured with what we have, to try to find what separates the bucket of Parkinson's statistically from the bucket of people with healthy controls. And in that process, we refer to it as a biomarker of Parkinson's. Now, notice that this idea is logical, but is in defiance of the concept that each individual with Parkinson's is different. It is a bit of a cognitive dissonance to say that everyone is different, but that we will find a biomarker of Parkinson's progression. Because that if everybody's different and there is something that's common across everyone with Parkinson, well, then that isn't going to be as relevant to the individual. It's going to be telling us something about the population, the people that have something in common, but nothing about what's going to separate Jim's Parkinson's from Mary's and George's. Actually, this is what's borrowed from other fields of medicine, most importantly from oncology, is a model of biomarker development where we, by we, I mean somebody like me at the bedside, doesn't get to say what the truth is. We can say what our diagnosis is, but we don't assume that's the truth. So that's a study of aging. That is to try to understand why is it that we're aging in funny ways, some of which we give the name of Parkinson's to, some of which we gave the name of Alzheimer's to, et cetera, et cetera. The idea would be that what is independent as a variable is the biological signals, not the clinical diagnosis made at the bedside. And we look for those outlying signals that have a particular relevance, because today for those signals, there is a therapy that in fact corrects them. And that means that we could then match the individuals that are in the range that we believe is associated with accelerated aging, and only them, not others, to the therapies that already exist that correct that problem. And that is essentially how precision medicine has worked. At the bedside in an oncology clinic for somebody who may be thought of having some kind of cancer, the oncologist said, well, you have breast cancer, but we don't know what it is. That is the honest assessment. If we were to be oncologists in Parkinson's, we say, well, we give this the name of Parkinson's disease, but we have no idea what it is for you. We would have to do a variety of different tests to be able to understand what disease you actually have, to then be able to treat your disease. Meanwhile, here is levodopa to make you feel better. That would be an honest approach to Parkinson's that we're skipping for the most part. So that is a lot of what's happening in the CCBP, the Cincinnati Cohort Biomarker Program. The methods paper is one that I've just copied on the right lower corner, and it's gotten to be referenced by a number of other institutions, because we are not going to be the only ones doing this in the future. We shouldn't be the only ones doing this in the future, because it's a hard thing to do, to recruit people with a variety of different conditions, Parkinson's among them, but not to assume that that diagnosis is the truth. That diagnosis is a placeholder diagnosis. We're using it because it's what makes sense to us now, but it's not because we think there is anything biologically unique about it. And the idea is to use this as a platform to identify the individual biological abnormality that is driving the Parkinson's in one person that might actually not be in others. This is divergent biomarker, not a convergent biomarker, not a thing that happens across everyone, but a thing that happens in very few people that happens to be relevant because by identifying that signal, we can then match that individual to a therapy that already exists so that we can conduct what in the future will be N of one. These are N of one is a term, N of one clinical trials are a term used for doing a clinical trial with actually one person. That will be what we are aiming for. And just as last week, we achieved our 1,000th patient enrolled in our study. So I will.
And she's on.
Yes.
Your 1,000th patient is on with us.
Is that right?
Michelle. Mm-hmm.
Oh, well, thank you very much.
Here I
Michelle, huh?
am. Here I
There
am.
she is.
Oh, thank you very much. See, this kind of thing couldn't happen unless we're all connected in this. Meaningful changes will never occur in the vacuum. So I thank you, Michelle. I thank everyone, because to get to this point has been sweat, tears, maybe a little bit of blood. So it's taking quite a bit of work, and I recognize many of you, of course, are already part of it. So thank you, and thanks, Maureen, for pointing out the milestone. So and I wanted to show you, this is sort of we have a website that is available, and as of a couple of days ago, this is a screenshot of all the samples available. Because also one of the things that we are now at the face of is to pick and choose which different scientists and maybe different companies could help us do the quote fishing expedition we need, right? Because we know that the only way to measure success in this study is not by saying we look at the many things we're collecting, or for that matter, look, with this we can now classify people into different biological subtypes. Sure, be interesting, but we're not that's not the goal. The goal is not to determine how many different types of Parkinson's there are, but to find those who today have a disease-modifying treatment. That's the goal. And it might just start with one person, of course. We want to make as many people as possible, but that's the phase in which we now are. And in fact, I show you this very busy slide simply to tell you that of the top 5 neuroprotective interventions already tried in Parkinson's as a group, we have been applying for funding to different organizations to try to get to now what would be our next phase of development, which is the actual assays validation and deployment. The assays are the kind of thing that says something about the biology about which is relevant for this, and it has to be tailored for this treatment. So these treatments are available. They are kind of gathering dust in a proverbial pharmacy shelf. We don't know who they are for yet, but we're hoping to find those that will be, of course, ready for them. And our goal, I mean, we've been designing this thinking that this is the decade in which precision medicine will be realized for Parkinson's. And there is no reason why it cannot. Our excuses have been always that the trials aren't good enough, that the measurements are insensitive enough. One of our favorite excuses is that people are too advanced by the time they come into trials, and no. Imagine that our oncology colleagues would have said that the trials failed because people already had cancer. No, the demonstration of efficacy is done when people have the disease. Now, once you match, what is it about the therapy that worked in certain types of individual, you find the assay, and now you bring that earlier to an earlier time point, so that then you can begin to treat people earlier, because that's how prevention is done. Outside of immunizations, there are no treatments ever found to be effective in the pre-disease state or the earliest state that wasn't first demonstrated to be effective at the advanced disease state. So we should be able to we should not get away with the excuse that people are too advanced and this is why we're not getting results. We should really just recognize that maybe the first successes will be very small, but that is perfectly fine, because that's how successes begin to occur in any field of medicine. One of the things we have advocated with the NIH is that when people are asked to participate in a clinical trial, they need to ask, and of course, but now that we're talking together here, I want us all to be mindful that if anybody gets to be invited to a trial to slow Parkinson's progression, you need to ask, why me? And if the question is, well, because you have Parkinson's and you are early, that isn't good enough of an answer. No. Why me? Why would it, what you're trying to use to slow my progression, why would it slow my progression and everyone else's? Or would it just slow mine and perhaps a few others? And say, well, no, but we know you have Parkinson's because we've done this test. And I'll talk about the test in a moment, because that's the next hot topic we're going to discuss. Oh, you have a positive seed amplification assay, so you are perfect for this therapy that will remove synuclein from your body. I'm going to tell you how bad that idea is, but you should say no. And in fact, in the University of Cincinnati, we don't offer you any of those studies.
Giving good information.
What's that?
He is too detailed sometimes.
Yeah, doctors do that.
Race.
They're too darn smart for their informations. Yeah, sometimes they lose you.
Ray, you're not muted. If you don't mind muting your phone, your computer, that'll be great. So what I wanted to make sure that you all are mindful of is that the tier 1 for clinical trials is bioassay based selection. What test is there to show me and show that institution or person inviting me to a research trial that demonstrate that I'm truly a candidate for a quote neuroprotective intervention, a medication, that some kind of intervention that will slow my progression? Because no enhancement in trial design or execution can overcome a mismatch between treatments and patients, right? The what and the who. The what must be connected to the who. If they're not connected, then we're not going to get successes. So now moving on from precision medicine to something called rescue medicine, I want to start by saying, remember, what we see is what we think it is. And what we see through autopsy studies that gave us the idea of what Parkinson's is but the end of many biological processes. And what happens is that the Lewy pathology, truly, that thing, the Lewy bodies are truly coming from a protein called synuclein. And synuclein is what we are losing in the process of transforming into Lewy bodies, or we call it Lewy pathology as well. We're losing that because synuclein is a very important protein that reacts against anything that the brain should not have. And as we grow older, there are exposures in the environment. Some of them are toxic, some of them are biological, some of them are infectious, that generate that transition from soluble, meaning dissolvable in water, alpha-synuclein monomers. This is the protein from that ultimately then undergoes a transition into Lewy pathology. And this is why often what we see is not what we're losing, and what we're losing is very, very relevant. It turns out that in Parkinson's, when you're looking at, this is one of many studies just to show you that if you, PD is Parkinson's here, HC is healthy controls, and you see that in all studies, there is a lower concentration of these different proteins, alpha-synuclein, A-beta-42, total tau, phosphorylated tau. So there is a loss of proteins because Parkinson's is conceived as a neurodegenerative condition. And we're losing something that we're not quite paying attention to. When we, a number of years back, did a study that was just looking at two very objective variables. In the horizontal axis is the proteins that we can measure in CSF. CSF is cerebrospinal fluid. And one protein is alpha-synuclein. I told you that's where Lewy bodies form. A-beta-42 is where amyloid plaques are formed. This is, the amyloid plaques are what define Alzheimer's. And on the vertical axis is the brain volume. And you see that although the study wasn't designed to answer this question, there is a linear relationship between the levels of the protein and the brain volume. The higher the levels of the protein, the higher the brain volume, the normal the brain is. But the lower the levels, of course, that means the more atrophy there is, the lower the brain volume. So it's very important to know that to date, the only biomarker of progression across everyone with Parkinson's that we have understood as being meaningful is the levels of synuclein. As you can see here, this is just one of the things we've actually learned from the PPMI is that when you adjust for what's referred to as confounders, a variety of different things that could explain the results, you adjust statistically for all of them, the only thing that emerges as significant, and this is in the last part, P is the probability, the P value, the probability value that this is true, and you can see that the only one is alpha-synuclein levels. So the lower the levels, the faster the progression. And that's important because we have entered an era in which we have a different test for Parkinson's, and it's not the synuclein test. As I mentioned, it is this one called the synuclein seed amplification assay, and it's being referred to as the biological definition of Parkinson's. And that is a really, really problematic concept, and I'll show you why that is. But essentially, if you are seed positive, if this assay is positive in you, and this is all I can say, is positive or negative. If it's positive, you have Parkinson's. Even if you have no symptoms, you have biological Parkinson's. And it is really a dangerous idea because it turns out that most people in the population will be as positive, just like most people have amyloid plaques, but very few of those who are positive will go on to develop Parkinson's or Alzheimer's, because this is a reaction. This is a consequence of a reactive brain, not a cause. Proteins do not evolve toxicity. They function when they are normal. They cease to function when they become aggregated, like when they aggregate into Lewy bodies. So normally, and this is a very simplified way of telling you that normally, the concentration of proteins in the brain and in the spinal fluid is in the picomolar level. Picomolar is 1 million times below what we typically would measure in many other. I mean, it's a very, very small concentration. And that's why PG per ml, that's picograms per ml, is the units we use to measure alpha-synuclein. Well, in the laboratory, there is a test called the seed amplification assay that markedly increases the concentration of what's in the tube. We call it the reagent. That will be the solvent. This is where, if you then put a tissue there that contains aggregated synuclein, and that's depicted by that clumped up on top, it requires a super saturated reagent in the micromolar range. So from picomolar, which is normal in the human brain, to micromolar, which is a million times higher concentration, a million times higher concentration that happens in the brain. And that is a good method to identify if a tissue you're testing has synuclein in an aggregated fashion. And if so, then it tells you that it probably there is that thing happening in the brain. And if somebody has Parkinson's, then it does support the diagnosis. But what is being conceived as is that if you have a positive seed amplification assay, you have a demonstration that that's happening in your brain, that you have seeding of synuclein in your brain, seeding meaning intended as replication and propagation of this in the brain, and that is a demonstration of biology. In fact, is neither. So this has been now used to form a new staging system for Parkinson's disease, which has a variety of different assumptions, supposed to be linear. But the key thing is that if you are S positive, you have the disease, and then there are a variety of other things that you are other biomarkers and so forth. I'm not going to bother you with this, but I'm going to show you how not true this is. So if you have a positive seed amplification assay, it's actually good to support the clinical diagnosis of Parkinson's because it has two things called sensitivity and specificity, which are high. The closer to 100, the better they are. So this is as good a test of Parkinson's as we have, but it's not that much different in quality as a DAT scan. You all know, if you have symptoms of Parkinson's, you have a positive DAT scan, meaning lower dopamine in your brain. That's a good, sensitive, and specific test for the clinical diagnosis of Parkinson's. But doesn't discriminate any type of Parkinson's. So it's motor, non-motor, whether there's depression, cognitive difficulties, not cognitive, except it doesn't. It is not able to quantify how much of the Lewy bodies there are, nor how much less of the monomeric, the normal protein alpha-synuclein there is. And that's why it doesn't correlate with severity. It doesn't tell you anything about the rate of progression, if any. It cannot be used to subtype, which is the most important element in precision medicine, in disease modification. And it cannot even be used to monitor treatment response because once positive will never turn negative unless we remove the synuclein from the body, which would be highly undesirable. So this staging system is really quite a mirage because it was tested in the Parkinson's Progression Markers Initiative, and it actually showed that when you use the seed amplification assay as an anchor of the staging, it shows that 70% of patients at baseline are already in stage 3 or 4 or 5, which makes no sense for a staging system that should then be unidirectional, because as you will see from that data, it shows something called stage regression with levodopa, which would make no sense either. And it doesn't correlate with any of the currently used biomarkers, some of which we think of are implying progression. NFL is neurofilament light, is a marker of degeneration, A beta 42, no correlation whatsoever. So there is refutation of a staging system. And I think that's important because people often ask, well, what's my stage? And the honest answer is that there should not be a staging system because we have never been able to predict what's ahead for anyone. And there are people that do very well. Of course, there are people that give Parkinson's its bad reputation because they may have a malignant expression of it, right? So there is a variety of different people. There is no such thing as a staging system for everyone. And this, in fact, was recently created and is being pushed for by the Michael J. Fox Foundation. Is really a mirage of a staging system, not anything that represents true progress. So alpha-synuclein is actually a victim, is not a villain. Alpha-synuclein doesn't ever increase to toxic levels. You would think something that is conceived to be toxic should go up, and it doesn't. The levels go down. The only biomarker that predicts progression in Parkinson's is lower levels of alpha-synuclein. The seed amplification assay, SAA, doesn't, as I've shown you. And the elimination of Lewy bodies, call them Lewy pathology, has shown no benefits because the Lewy bodies do nothing to the brain. They are just a marker of a reactive brain, not a maker of disease. But rescuing the loss of alpha-synuclein could be. So here's just a way to kind of try to end this presentation, a bit of a figure to kind of give you an idea of where we are with regards to the entire panorama of research. So synuclein is a very central protein. And I told you already that to get to Lewy bodies, we must lose the normal synuclein that's here. And synuclein functions when it's normal, and it ceases to function when it turns into these Lewy bodies. In the context of Parkinson's, there is a clear loss of synuclein. This is shown in the green arrow down here. The synuclein is progressively lost because it's transforming into Lewy bodies. And if the brain cannot generate enough of synuclein, then the condition begins. And this is really when we think that the loss of function is compensated up to a point, and at some point it ceases to be compensated. Now, we know that the cause of why synuclein transform into Lewy bodies is going to be different in different individuals. And that's what CCBP is about. CCBP is about understanding what makes each of us different from one another as it relates to Parkinson's. But the other aspect of disease modification is rescue, is elevating the synuclein levels that are becoming depleted, bringing them above the compensation threshold, and that's rescue medicine. For now, the therapeutic pipeline, as you've seen, it includes 70% of all drugs in the pipeline. 70%, 69, all of them are trying to remove the Lewy bodies or prevent its formation. And none of them are directly or indirectly trying to promote the function of synuclein or the levels of this normal protein. So the master plan that we have is something that we've been, I think, fortunate to capture some attention in at different levels. Still, of course, the status quo remains incredibly magnetic, unfortunately. But the master plan is first and foremost to move from protein clearing to protein replacement. The idea is that protein aggregation is really common as we age. It's not a cause of Parkinson's. It happens to be common because among the few that have Lewy bodies that develop Parkinson's, that is just telling us the brain has been reactive for a while. But the proteins from which the Lewy bodies come, which are the synuclein, can be replaced. And that is rescue medicine. Moving from trying to make sense of what is it about Parkinson's that somehow makes it one disease to what is it about each of us with different brands of Parkinson's that gives Parkinson's this remarkable heterogeneity, its diversity. And that is the finding of individualized biomarkers to personalize disease-modifying treatments so that then we can match therapies only to those who are biologically susceptible. And future trials will be looking at the assays of individuals that would benefit from something that we already know exists. We don't even have to reinvent the wheel. We just need to know who the therapies that we have are for, and that's called precision medicine. And by no means these are mutually exclusionary. They can be part of a convergent approach to moving toward really slowing progression, and even reversing the disease, one person at a time, one subtype at a time. And with that, I thank you very, very much for your attention. This is a picture of the CCBP group on the left lower. You may have met a number of them. We have a few other people that have come onto the board. In the left upper is a larger picture of the group. You can see Marine up on top there. We are very fortunate to bring people from different parts of the world. We are training 4 clinical movement disorder fellows. These are neurologists that are wishing to become experts in the field. And we have 3 research fellows, people that are becoming training research of Parkinson's. So we're very proud of what we have in Cincinnati. And with that, I wanted to thank you for your attention and leave now the room for questions. Thank
So
you.
the first one that came through, Alberto, is what new promising drugs are out there and is UC offering them?
Yeah, so the drugs that are out there are in the area of symptomatic enhancement. So I mentioned earlier that I was going to devote this talk to disease modification. But in symptomatic enhancement, we have actually great treatments out there. We have a really excellent extended release levodopa formulation called Crexon. The experience so far has been very, very positive. Of course, no therapies are for everyone, but it looked as if for the ones that we've been able to convert from carbidopa levodopa immediate release to Crexon, the results have been good, generally speaking, and that's very helpful. And then we have 2 new advanced therapies that are harnessing the principle of an infusion system, an infusion of levodopa or of apomorphine. Apomorphine is a dopamine agonist and is actually equal potency to levodopa. And so we have 2 infusion systems. We often have said in the past that levodopa is to Parkinson's what insulin is to diabetes, and now we have our insulin pumping Parkinson's that is actually quite helpful. Now that, as you can imagine, is a complex setup, but for people who have really great response to levodopa, but that response is short-lived or and it cannot be optimized appropriately or is associated with side effects or issues, then an infusion system can indeed be the next solution and certainly of lower risk than deep brain stimulation, however effective, of course, it is. So those 2 categories, the extended release levodopa and the infusion systems, are the newest entrants into Parkinson's treatments, and I'll mention a few words about them further at the Sunflower Symposium next month.
So there's a question about the DET scan versus the alpha-synuclein seed amplification assay test. So if you're looking for confirmation of PD, which one would you choose?
Well, it's a good question. Probably from a cost perspective, the seed amplification assay is cheaper than the DET scan.
Does insurance cover it?
Yes, it does. Now, the thing is at the moment, the seed amplification assay is validated only in spinal fluid. So it does require a spinal tap. Though there is a different test of synuclein called the skin biopsy, and that is just requiring a punch biopsy. It's a very simple biopsy test, although it requires 3 biopsies, one in the neck, then another one behind the knee area, and then another one behind the ankle. So 3 different spots. So it takes a little bit of time to get it done. It's about a half an hour total, I think, in general. That one is covered also by insurance. Doesn't require spinal tap, as you can imagine. I prefer that to the seed amplification assay because that one is quantitative it tells us how much of the Lewy bodies there are in these skin regions. Though it doesn't yet, and I've talked to the company, and the company is presumably working on this, it doesn't yet offer us an indication of how much less of the synuclein there is, because you need both ends of what's referred to as protein homeostasis. Proteins begin in a normal state and ends as Lewy bodies, right? In the case of synuclein. But if I'm also I'm only giving information about one state of protein, then the information I get is partial. And whenever you have partial information, you end up getting stories that aren't really quite as accurate.
And in the lecture last year, you mentioned Lewy bodies were the result, not the cause of Parkinson's pathology. Are there any new therapy candidates in the last year to target that?
So there are many candidates to target Lewy bodies, and this is the thing that we don't want. There are still trials. It's quite remarkable. Prasinezumab is a monoclonal antibody. It's an antibody against Lewy bodies, and it actually works well. It was shown to be futile, but the company decided that they had looked at wearable technology data that suggested that they were actually improving, even if at a level that was not quite noticeable to patients. So they are actually moving into another study for that. These studies are very profitable to institutions. So if we were to look at care and research on the basis of how much money we can make, that is something we should do. We cannot ethically do that study. We know that there isn't anything to be gained from that, and so we cannot we could just not encourage anyone to participate in those studies. This is one of the reasons why I say that it is not about lack of money. It's not that we don't have enough money in the field. It's that the money gets used inappropriately. And we can double the budget on research for Parkinson's. If we continue doing what we've been doing for a while, we will get nowhere. And I just want to make a comment here. To me, there was a point when I thought, well, I guess this is still somehow working, right? Because there are, I guess, I don't know, jobs created with the research and all that, and I guess companies that have a stock that just dip for a little bit when they present their negative results, but then they jump again on the hype of the next molecule. Sure, if it's all finances, I suppose that who cares? But I care because in the process of going through this research, people are at best not helped, but at worst they're harmed. So this is something where that's a line that's very hard to cross. If there is something that has a greater potential of harming than of helping, we cannot insist on doing that. And one of the things that I say to in meetings with colleagues, I say we have to come into a point where we should say, if a trial fails, one possibility is that the hypothesis driving that trial is false. If we cannot falsify our hypothesis, we're in trouble because we're going to continue doing the same and bringing more money into the same kind of thing and end up with something that the field of Alzheimer's has. The field of Alzheimer's has 2 new monoclonal antibodies, and they seem like they are progress. They are but the illusion of progress. And I can tell you later, if you wish, why that seems good, but it is actually harmful.
Does CCBP rely on any monies from the NIH?
So every time that we've tried to get NIH support, we have not been successful at doing so. I think that eventually we will. My sense is that we will, because the NIH has to their credit, they set up a meeting. They invited me. We presented some of what we're doing. We presented some of why the status quo cannot continue to dictate what we do, because we're not going to get any results from it. And I think that they are open to it. The problem is that the NIH, like all the other foundations, are advised by a panel of experts, and many of them are have a lot at stake that they need to protect, I guess, if you think of a legacy perspective. And it's an imperfect system whereby the NIH could be open to these ideas, but then they present these ideas to a panel of reviewers, and the reviewers say, well, this is crazy. We don't need to spend this money on this. And no, this is going to lead us nowhere. These people don't know what they're doing, et cetera, right? And it is very unfortunate because then the intent is there, but ultimately we have not been able to succeed there. We're fortunate to have had the support of many people in the community that have provided the means to keep this going. So that has been helpful. But without, it's one of those things that we recognize if it hadn't been for that support, we would not be where we are. It's been liberating to have the opportunity to develop this program, despite the fact that it is quote unquote crazy when you consider where we supposedly should continue working on.
This is a great question. For as much as we preach exercise, is there any evidence that exercise alters biomarkers?
Yes, there is. Now, I have to say that I take the whole field of biomarkers with a big deal of caution, because sometimes biomarkers tell us something that may not be relevant to people. But by and large, in the field of exercise, virtually every study that includes biomarkers have shown biomarkers moving in a desirable direction. Exercise is probably the only disease modifying intervention we have. We say we don't have any, but exercise is the exception to that, because exercise yields a variety of different changes at a molecular level that no therapy can do. And so it's just a rush of a variety of different things that improve. So it's likely that you cannot get that with any therapy, because it would be impossible. It also tailors the benefits to the individuals that are doing it. So it's not just the biomarkers, is that we recognize that the disease is altered by exercise. No, if we were skeptical of that, and some of us, I suppose, I was always very keen that I recognize people that exercise did better, but it was also always this chicken versus egg situation. Is it because people exercise and do better when they have Parkinson's, or when they have Parkinson's? But I think it doesn't matter, because when the pandemic came over, and people whose only source of exercise was a gym that closed, and they now stopped exercising, they clearly decline. So exercise is absolutely essential, and it is today the only thing that makes a difference in terms of disease progression. And you can, it's the one thing you can do. Unfortunately, you have to sweat it and pant it because you cannot get it in any other way. But it is actually very different than anything else that we're trying to do. It's a non-pharmacological disease-modifying intervention, as far as I see it.
There's two questions about alpha-synuclein. One is to enhance on the decreased levels that predict faster time to progression. But the second is important too. If you've been diagnosed for a while, would it be helpful to be tested for the alpha-synuclein level?
Not really if you're being diagnosed. The only reason to, in the future, be tested, and I hope that that future will come, is that we will have an alpha-synuclein analog, meaning a molecule that looks exactly like alpha-synuclein in every bit. And then we would want to know what levels of alpha-synuclein people have, so that we know where they are and where we need them to be. And that would be them for the purposes of identifying them for synuclein enhancing intervention, and B, to determine if we are where we need to be by the time we determine the effect of that intervention. So for now, there is no practical purpose, unless it is driven by someone that might say, well, but we have a trial for an anti-synuclein therapy. No, you don't, because obviously the anti-synuclein therapy trials are using this test as a way to select people that for sure have synuclein affected as part of their Parkinson's. But remember that we don't want to bring down synuclein any further. So antibodies against synuclein make absolutely no sense. So that would be another reason that you might be asked to consider this, but I would argue do not do it because you don't want to go in that direction.
There's a question about rescue medicine, which when you say rescue, this person thinks about albuterol and asthma, but how do you define rescue in Parkinson's?
Yeah, in Parkinson's, rescue medicine would be to literally rescue the levels of the synuclein protein to above the compensation threshold. Threshold is how low we can endure lowering of synuclein before we develop symptoms, and we want to be above it. We've shown in research done at the University of Cincinnati that, in fact, there is a level that is important for everyone to keep. And the reason why so many people in the community have plenty of Lewy bodies, plenty of amyloid plaques and other, quote, pathologies, and are normal is because they have managed to keep those levels high. Interestingly, there is a diet called ketogenic diet. It's actually, every time it's been studied in any disease state, it's been shown to be effective. It's just a hard diet to do.
Really follow.
To follow. But there are many mechanisms of the therapy, how that works, and one of them, it increases the levels of proteins, and including A beta 42, which is a very important protein for all sorts of things. So there already is a treatment to enhance proteins, and that's a ketogenic diet, but it's a hard one to do. Although every so often I do suggest that one to be considered by people who have cognitive difficulties, because one of the best improvements of the ketogenic diet is in cognition.
And is there any research that elucidates the cause of the decline in alpha-synuclein?
Okay, that's an important. It's like asking what causes Parkinson's. Well, the cause is going to be different in different people, and it is the reason why when we are seeing each other at the clinic, what we do is reminding ourselves that we're using a label, Parkinson's, by no meaning we know what that is or why that is. The why question is going to be individualized. What's going to be the correct why answer to Mary's Parkinson's will not be the same for Sally, for Greg, for Mike, etc. Right? This is not going to. So I think that the questions that we're trying to answer will be different than the questions we've posed ourselves, because it did make sense back in the day to say, well, we need to find out what causes Parkinson's. If we know what causes Parkinson's, we'll then treat it, right? Well, we felt that Parkinson's was caused by Lewy bodies. And so by now, we should have cured it, because we have had great therapies. I told you, and still, I show you a figure, still nearly 70% of the pipeline of research is therapies to remove Lewy bodies. We still don't get out of the same mindset. It requires a paradigm shift, and that isn't necessarily an exaggeration, because if you think about it, one strategy is to add proteins to the brain, but we still think we're still operating under the paradigm that proteins are toxic. That's crazy. That would make no sense. So the adding protein is something that will not require the knowledge of answering why the synuclein is affected. So that's important. That's why I say that is still allowing us a lumping approach. But to truly answer the why question, why the protein is affected, that's going to be different people. Infections can be very, very well demonstrated experimentally that infections markedly increase Lewy bodies. The expression of synuclein goes up because synuclein is part of the, it's called the innate immune system. It's actually, that's why we have synuclein all over the body. Synuclein is actually even in red blood cells. It's literally everywhere. That's why we do a biopsy. Anywhere we do a biopsy, we'll find synuclein because it's there for us. It was preserved by evolution because it has so many important functions. We cannot live without synuclein. And so that's why one strategy to rescue is to rescue all the functions of synuclein by bringing the levels up to normal, which is one of the simplest ideas in medicine. The rescue approach is like the rescue of insulin for diabetes is very similar in that regard.
In respect of everybody's time and yours, I think we can wrap this up. I really appreciate your being willing to do this for us again. I think we'll make this a yearly event if everybody likes it and if he's available. But thank you a lot. For those people who may not know about the CCBP, please ask at your next clinic appointment. We try to offer all our research to our patients when they come into clinic. And we always need healthy controls too. Correct, Alberto?
Absolutely. Yeah.
Okay.
So anybody who wishes to be to control us, please come over.
Okay, I want to do that. Control you.
That's right.
Impossible.
Impossible.
All right. Becky, you have a few words to say?
Yeah, before we let everyone go, just thank you so much, Dr. Espay. This is just great of you to do this with us on Saturday morning. And thank you, everyone who generously donated to this PDEDU. It was so gracious of you, and we so appreciate it. And last but certainly not least, steady strides. You heard Dr. Espay, exercise works. Steady strides is September 27th. So please go ahead and get signed up on Run Sign Up. That would be terrific. You bringing us up for it, Chris? There you go. Thank you. And thank you all so much for your Saturday morning.
Bye, everybody.
Bye. Thanks, everyone.
Bye.
Bye.
Bye-bye.
Thank you.
Thank you.
Thank you.